Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Have a very complex and a long procedure, so if you guys want to make yourself a cup of tea, feel free. And this is of a patient who attends, I think, twice a year, and they have a condition called eczematous otitis externa. The term otitis externa is an umbrella term given to an infection or inflammation of the outer ear. And the cause of this patient's otitis externa is that they suffer from eczema in their ear, and as a result they have a high turnover of dead skin, and this dead skin is not able to migrate out of the ear. Instead it collects and it becomes damp, it macerates, it becomes very sticky, almost like a butter-like consistency, and it's the most probably for me the most difficult type of wax or dead skin in this case to remove. It's really difficult to suction. You can't scoop this out, because if you do, you're just going to spread it across the canal wall as opposed to removing it. Of course, you can't use an ear hook, it's just too soft, and similarly, you can't use forceps. And what's probably the most difficult part of this procedure, especially at the beginning, is to kind of ascertain exactly where you are in the ear canal. So I want to see some of the canal wall, because the last thing I want to do is bump into the canal wall with the suction probe, and I want to know where the eardrum is. So I've cleared this more lateral dead skin, but again, I'm not really seeing at the moment the side of the canal walls or the eardrum. So I'm just going a bit deeper. I'm using the Zollner suction probe, which is a 14 gauge suction probe, which means it's got an outer diameter of about 2 or 2.1 millimeters, and it just about fits. You can. Another complexity of this particular patient is how narrow the ear canal is, and their right ear, so this is their left ear, the right ear is actually even more narrower. So I'm just dilating the ear using the endoscope. I can begin to see some of the canal wall on the right hand side, so the posterior canal wall, but I really want to see the eardrum, because I don't know how thick this layer is. Some of you may be wondering why I'm going straight to the middle, because this patient has come to hear better. So what I wanted to start off by doing is visualizing the eardrum. Once I visualize the eardrum, the patient can hear, and everything else for me is a bonus. So when we're performing earwax removal, it's not, and I understand why people might sometimes get mistaken, but it's not like washing a car. The purpose of this procedure is so the patient can go away hearing better, or any other symptoms they may have, earache, tinnitus, for example, itchiness. These symptoms are improved or they're alleviated. It's just not possible for me to remove every little last bit of debris from this ear. So a spoiler alert, I was contemplating whether to upload it actually for that reason, but this is the reality of the more complex cases that we do. This patient is on medication for their eczematous otitis externa, but they still need their ears cleaned on a regular basis. Without the medication, they probably have to come every couple of months, so every 6 months, although it sounds a lot, and it is quite frequent, but without the medication that they take, it'd be a lot more frequent. So again, I'm just slowly approaching the eardrum, and I can start to see some of the eardrum, which is fantastic. So I'm now able to gauge the depth, because the last thing I want to do is push this suction probe straight through the patient's eardrum. So we're having to do it in gradual steps. And I'm still using the Zollner suction probe here purely because with the smaller suction probe, the fine end, it's just going to get blocked, and it's not going to be very effective. So see, I'm just kissing the surface, and you probably see the eardrum actually moves on occasions with the suction as I'm coming away. Now, with this type of condition, you do not use water, so some people may be wondering why we just don't wash it out. The patient's got chronic otitis externa. This patient has to avoid water in the ear. Any water in the ear is going to exacerbate this. It's going to lead to an ear infection, which is inflammation, increase of bacteria, potentially fungi. So this has to be performed in the absence of water. In theory, water would be really, really good. You can give it a good wash or a good rinse, but that's going to lead to long-term problems. And in fact, if this patient ever does get water in the ear, which occasionally has happened when they're showering or when they're swimming, it really does lead to a severe ear infection, what we call swimmer's ear. I have put some drops. I've tried to avoid using drops actually initially, just to see how well it works without drops. In the past, I normally would put some olive oil drops, which I just have done here. But I wanted to see how well the procedure goes without the drops, because unless you try these things, you're not aware. So sometimes, although I feel the drops is going to be beneficial, it's good to see how it is without the drops for future reference. And actually in the mainstay, the main bulk of the procedure is actually performed. We can see the eardrum, and I was able to do that without any drops. So everything now is somewhat for me a bonus. So I'm going to try and remove this mushy butter-like dead skin that's sitting on the surface of the ear canal, and I want to do this without making contact with the canal wall if possible, because that will be uncomfortable. If anyone's had their ears cleaned before and the contact has been made in the ear canal, you're probably fully aware it's not a nice feeling. It's really painful. It's very acute, sharp pain, especially deeper in the ear where it's made up of bone. So the bony part of the ear canal, the inner 2/3, it's just lined with a really, really thin layer of skin, less than 0.1 millimeters in thickness, whereas the cartilaginous portion, the outer third, is made up of a thicker layer of skin, and that layer of skin also contains some fatty tissue, some adipose tissue, so it almost acts like a buffer. So I've now reverted to the fine end because we're working on the anterior recess, and it's very minimal space in this patient's ear canal. If I try to remove this with the full Zollner suction probe, I'll probably very likely make contact with the front part of the ear canal on the left, which would be uncomfortable. We can see the hammer bone running down there. That's that kind of, it looks, it's full of blood vessels, but it's that red kind of landmark running from about just on top of the suction probe there to the center. So that's the hammer bone. Again, it's good to have these landmarks because then I can then picture the remainder of the eardrum. Now I've decided just to zoom in a little bit because I'm working really close on the eardrum. Now when you zoom in, obviously it gives you more precision. I can really it gives me better depth perception as well, but if you over zoom you do lose a bit of clarity, unfortunately. But it's that trade-off, and I think at this stage I preferred using the zoom. So you can see just how much better detail I can get, gives me better depth perception, and it also means I don't have to insert the endoscope in too deep. When you're working really close to the eardrum to get additional magnification, you generally go in a bit more with the endoscope. But this patient's ear canal is probably a bit longer than average as well, and when you go in too deep with the endoscope, it can start obstructing against the instrument. So having the zoom function on our ClearWax app is really, really helpful because it means that I can work deeper in the ear but without over inserting the endoscope. So I'm just navigating those hairs. Now we're working on the front part of the ear canal here. And you can just see just how mushy and buttery this type of skin and wax is. It's really, really, it's not one of my favourite types, as I alluded to earlier, to remove. And actually with this patient, we only book them in at the end of the day, at the end of the clinic, so my last patient, because it generally takes a long, long time to perform. So I don't want to be having this patient in during the middle of my clinic, because it's just going to mean that I'm going to run behind and I'm going to have other patients in the waiting area, patiently waiting for me. So I'd rather have this patient at the end of the day, so I can take my time and there's less pressure, so you're not looking at the clock. So I've just zoomed out for this bit because we're working a bit more laterally, probably the centre section of the ear canal. And I'm just hovering over that, the front section of the ear canal. Just want to avoid contact. And unfortunately, with this type of consistency, there was having to come out the ear quite often because the suction probe got blocked. So I'm just working in the attic region, also known as the pars flaccida, and this is the top part of the ear canal now. think that was the hardest bit to try and reach and gain access to. See, this patient's got quite a few trachea hairs. We also call them terminal hairs. We have two types of hairs that sit on the surface of our skin. You got terminal hairs, like the ones that you've just seen at the entrance, and they generally provide more protection, so they protrude outwards, they prevent foreign bodies, invaders from entering the ear. And then you've got vellus hairs. Vellus hairs are like peach-like hairs, and they're almost invisible, and they are more designed to help keep the skin warm. So air gets trapped in between this vellus hairs, and it warms and it keeps the surface temperature of the skin at a comfortable, warm kind of level for us, so we don't get too cold. And also, they also do secrete a lot of sebum. So do the terminal hairs. They have got sebaceous glands attached, but the vellus hairs, because of the sheer quantity of those, they do produce a lot more sebum, which is an oily lipid secretion which helps to moisturize the skin and keep it healthy. So the sebum is also slightly acidic, so the acidity helps to avoid harmful bacteria which thrive more in neutral conditions, so at a higher pH. So it itself also has a function, these hairs. Again, I'm just treading very carefully here. I don't want to scratch the ear canal. So again, patients who have otitis externa, they generally also have a bit of inflammation of the skin. It's the inflammation, increased blood flow, which then causes the skin to produce more skin. The more skin the body produces, the skin is eventually going to shed. So you get a high turnover of dead skin. So the skin that lines the ear canal and also the parts of the body, it continuously replaces itself. So you have new skin cells that are formed. These skin cells form on the basal layer of the epidermis skin. So the epidermis skin is the outermost layer of skin. So typically the skin has three layers: the epidermis layer, then you've got the dermis layer, where you've got the hair follicles, that's where they attach, and also the blood capillaries. And then the deepest layer of skin is the adipose layer, or so it's some fatty tissue. It's also called subcutaneous layer or hypodermis layer. And it's in that top layer, the epithelial layer of skin, that itself has 4 or 5 layers. And the deepest layer is called the basal layer. And there, the skin cells undergo a process called mitosis, so they replicate themselves. And the daughter cell that's produced is pushed upwards into the next layer of skin, which is the stratum spinosum. That then gets pushed up to the stratum granulosum layer, where you start getting keratin that starts to form in bundles, and lipids being secreted, and the formation of natural moisturizing factors. So the natural moisturizing factors are very important when that daughter skin cell then goes up to the next layer. The next layer is called the stratum lucidum. And we only typically find that on your palms, or your fingertips, or the sole of your feet, where there's a lot more daily contact being made. So that extra layer just provides a bit more strength to the skin. But in the ear, we don't have that stratum lucidum. Instead, you have the stratum corneum. And stratum corneum is the most superficial layer of that epidermis skin, and it's about 10 to 20 layers of dead skin cells. So when the skin cells reach the stratum corneum, they're actually dead. They're metabolically inactive. There's no organelles, there's no nucleus, there's no intracellular fluid. Instead, that skin cell, that dead skin cell, is full of keratin, which is a protein, and the keratin has many useful functions. It's hydrophobic, so it prevents the dead skin cell from over-absorbing moisture and water. It also adds strength to the skin cells. So obviously the epithelial layer of skin needs to be quite rugged because it's continuously in contact with the environment we're in. So that keratin helps gives strength to that dead skin cell. And it also helps to reflect harmful UV sun rays. So it is very important. And also in that outer layer of dead skin, there's stratum corneum, you have these natural moisturizing factors. And the natural moisturizing factors kind of almost fight with the keratin, because obviously you want that outer layer of skin to be moisturized as well. So it tries to absorb external moisture to hydrate the outer layer of skin. Otherwise, all of our skin would be very dry and cracked. But the keratin helps to off balance that. So it kind of prevents over absorption of external moisture. So managed to kind of possibly remove more than I thought, if truth be told. I know some people are not going to like it because there's some residual debris there, but trying to remove every little last bit, I could be there for hours, and it's not going to add to, it's not going to provide the patient with any additional benefit. In fact, it could make matters worse. I can cut the ear canal, abrase it, which we don't want. So I'm moving on to their right ear. Now, this patient has left previously a very good review. It's a Google review, but it's something that I need to really push a bit more. Generally, it's always nice to get good reviews, so patients can, patients who are interested in your services can read, but I'm just really, really bad at kind of asking, and sometimes feel a bit embarrassed to ask, actually, but it's something that it's nice that patients, if they do off their own back, it's probably better in that respect. It's more organic, but this patient left a really nice review of their own willingness the last time they came. So they've had problems with their ears for many, many years, and they've seen many, many specialists, and they do have to travel quite a fair distance, but because it's twice a year, they're happy to do that. So the right ear is a lot narrower, actually. There's some crustiness of this dead skin near the entrance, but again, when we get deeper into the ear, it becomes quite mushy again. And although it was the left ear that was the worst one, I've probably found this one a bit harder to remove. And here it's the back canal wall, the posterior canal wall, that protrudes outwards, so it kind of invades the middle part of the ear canal. Normally it's the anterior canal wall, so the front part of the ear canal that bulges outwards and kind of takes some space into the middle of the ear canal, but here it's the posterior canal wall. And I kind of only know that because I've seen this patient a few times. So this is where ear anatomy is really, really important when you're performing earwax removal, because if you don't really know the angulations and the bends of the ear canal, and you've got an ear full of debris like this, you can quite easily bump into the ear canal because you just have no idea or appreciation of what may be lurking behind the wax or the dead skin. And so, as you can see, I worked really, really carefully there just to expose more of the canal wall, and now I'm a lot more confident because I can see more of the ear canal. I know where and where not to place the suction probe. There's a few more hairs here as well, which always makes it more difficult to suction. The hairs reduce suction power. Now, sometimes another reason for a patient to suffer chronic otitis externa like this is a fungal infection. This patient has been tested before, but it's just come back with normal levels of fungi that live in the ear normally harmlessly. So our skin has what we call skin flora, and the skin flora is basically an ecosystem of bacteria and fungi that typically live on the surface of the skin without causing any problems. They use the ear for shelter and for food. The ear canal really itself doesn't really benefit from the presence of them, but normally they don't cause any harm. However, when the conditions of the ear change, you can get colonization of more pathogenic bacteria, and these pathogenic bacteria typically work in more neutral pHs. That's their optimal breeding pH level. So for example, if you do get water in the ear, water is more neutral. In the UK, it's probably even more alkaline. And then you can get these harmful bacteria that enter and they recolonize the surface of the skin. So it replaces the normal bacteria. And these bacteria are more pathogenic. They're also gram-negative. So you get gram-positive and gram-negative bacteria. Gram-negative bacteria, both can be quite serious, but gram-negative bacteria is far more harder to kind of resolve with antibiotics. So the difference is with a gram-positive bacteria, you have quite a thick cell membrane, but with a gram-negative, although you have a thinner cell membrane, the bacteria itself is encapsulated in kind of a lipid capsule, which provides additional defense against antibiotics. Also, gram-negative bacteria are better able to mutate against an antibiotic, and once they have mutated, they're better able to share their mutation with surrounding gram-negative bacteria. So, so gram-negative bacteria are far more difficult to treat. With the fungi, when you get a fungal infection, it's the same fungi actually that lives in the ear normally harmlessly, and fungi are less sensitive to pH change, so they typically can breed in a whole range of pH levels, but it's more to do with moisture and humidity. So again, if you get water in your ear, fungi is going to really thrive off that, and if you've got a lot of heat, humidity in the ear, so warm climates are renowned for fungi infections, and normally fungi infections are more prominent deeper in the ear where it's a bit warmer. So, and the most common strains of fungi in the ear are Candida, Aspergillus. There's different types of Aspergillus. You get Aspergillus niger, flavus, for example. Aspergillus is typically, you see the fungal spores, and you see hyphae, which are these kind of woolly strands. With Candida, it's typically like a bit in appearance like this. It's probably a bit more white, creamy in consistency. Now, you probably see some specks here, but that's actually exfoliated dead skin cells that's stuck to the sides of this kind of debris, as opposed to fungi. So I can see some of the eardrum, but not all of it. Also with this patient's eardrum, and you'll notice it more once I start clearing more and more away, the posterior quadrant, so the back section of the eardrum is, and it is normally the case for all of our eardrums, but it's more prominent towards the entrance, but I would say here it's a bit more. So you've got the eardrum itself, its orientation in the ear canal, it's oblique, so it's not a flat surface. In the case of the right ear, the top left section of the eardrum is tilted more towards the entrance, and the bottom right is tilted further away from the entrance, so you've got this oblique orientation. But I would say this patient's eardrum is orientated and tilted more than the norm from the back, top left of the eardrum, should I say. So the patient could hear a lot better. I've zoomed in again just to give me a bit more precision. If I over zoom, then it's probably going to become a bit too grainy. And it just requires patience, really. I hope a lot of you are still watching. Probably some of you haven't decided to turn off, which is fine. But I know these kind of videos can frustrate a lot of you, but I wanted to upload it because these are, for me, the really challenging cases. So going to the front part, again, I'm almost like brushstrokes. I don't want to scratch this patient's ear, so I'm kind of like flicking away, and some of the material, like debris and dead skin, will stick to the side of the suction, but obviously we're trying to suction it as well. But using this flicking motion, it means that I'm always going away from the canal. I think in this here, there's a couple of occasions where the patient did experience some discomfort. I'll try and highlight those. You may be able to see it yourself. I can't remember if the patient did flinch, but I remember doing the procedure. And the great thing about the endoscope and also the wax scope is that subconsciously we've always got one eye on the patient as well. When you use a microscope, for example, or head-borne microscopes, you're looking through basically binoculars, so you're not seeing the patient, you're just seeing through the binoculars. So when we use the endoscope and wax scope, it's good because I've always got one eye on the patient, and I can remember the patient. I could see them slightly grimace, and then I stopped and asked the patient if they're okay. And you can just see how narrow this ear canal becomes as we approach the eardrum. And that's predominantly due to the back section of the ear canal bulging into the midline. So in a way, the procedure is actually complete. The patient can hear. I know there's a lot of debris still, but as I said, it's just unfortunate with this patient. It's just a case of maintaining the ear. There's just going to have to come on a regular basis. And I mean, they have seen ENT in the past as well. So, and ENT have just advised the patient to, the advice I give, avoid watering the ear. Don't poke in the ears. Because when you've got a slightly inflamed ear canal, if you poke in there, the skin is a lot more sensitive, and you could break down that outer layer of skin, and then you expose the inner layers of skin to the bacteria and fungi that I described earlier, which can then lead to an infection. So I think I'm using the full Zollner here just to get enough suction, because I found it difficult with the fine end suction probe. And you may be able to see already the underlying skin that's already breaking down. So it's a continuous cycle for this patient because of their eczema. Although I'm getting this kind of yellowy, butter-like dead skin, already underneath you can see the skin is just not very healthy. It's already shedding because of their eczema. Here I've got to be careful because it just about fits the suction probe. So this part of the ear canal, it's around 2 millimeters in width at least. And we know that because the Zollner suction probe just about fitted into that narrowing. And I think I do leave a bit more in this patient's ear compared to their left ear, the first ear, because it's just a lot more narrower. So again, probably just past the first bend here. It's a bit more crusty, this skin here. I've gone back to the fine end. I'm just hovering over, flicking away because I don't want to scratch the ear canal. And because it's a bit crusty, sometimes when you peel away a crusted bit of skin, it tends to peel all the way to the eardrum. So I'm hoping that's what's happening here. And happening a little bit at the top there. And this is for me why an endoscope, it's out on its own in terms of performing earwax removal, just to view the field of view. You can see all the way around, and it really helps in a procedure like this. So you can see that skin, underlying skin, it's quite red. Again, that's not due to us making contact, because as you saw, we're not making any contact. That's the surface of the canal wall. It's just their eczema and that inflammation which causes it to be red. And as I said earlier, increased blood flow in the ear means there's more skin cells being formed, and the more skin cells that are formed, the more skin cells that eventually die and then collect in the ear. So I'm just using the fine end now, going to the bottom section of the eardrum. So as mentioned earlier, I've got to be careful in this part because of the tilt of the eardrum. Actually, I didn't realise how narrow the ear canal was until watching it back fully. So even the fine end looks like a normal standard Zollner suction probe in this patient's ear canal. So this is the back section of the eardrum, and you're just hoping this all comes away, but it's a bit of a fight, and I'm almost gliding across the eardrum here to remove this. And because it's like a butter consistency, as I'm coming away with the suction, you can actually see the eardrum kind of move. So got to be really careful. So I've managed to reveal the back section of the eardrum. It's just that top that I found really, really difficult, and the top left region, but let's see how much more I can remove. I'm trying to remove this more so, it's probably not going to improve the patient's hearing, but because the patient has got their topical medication, I'm just hoping the more I remove, the more exposure these medications will have to the eardrum. So that piece came away nicely, but it's as fine as the space is there. So running through the middle of the eardrum is the hammer bone. And you can see there's a bit of crusted dead skin on there. So when I went to the right, the suction just fitted in between the hammer bone and the front part of the ear canal. This is the bit that I found difficult. I'm almost reliving it, watching it back actually. Because of the narrowness of the ear and just getting the access was quite tricky. So we're right in the top right section of the eardrum there. You can see there's a few hairs there which are matted against it, which have come away. Now, I did ask this patient if probably at that stage the patient found it slightly uncomfortable. You may have seen them kind of move slightly. I did ask the patient whether they used a cotton bud purely because all these hairs, but they know not to, but I did ask. But they said they do trim their ear hair, so I just advise them to seal the entrance of this. Again, I think the patient probably found it slightly uncomfortable there. So yeah, I asked them to seal the entrance of the ear with some cotton wool. So it prevents the hairs from flying, because it just does make it more difficult to remove. Actually, that might even be me moving, just because I know, because it's a really tricky part of the ear. I think that's when the patient found it uncomfortable. I could see them flinch a little bit, so I stopped. I'm happy with that. I can see basically the whole eardrum. There's just some residual dead macerated skin. Just his hair, and the patient actually found it was tickling the eardrum. So I'm going to just use the forceps and pull that away. There we are. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.